Hello everyone, welcome to a highly requested episode. Today is on bipolar disorder. This is one of probably many episodes we will do because this is a complex disorder and it has been requested so many times. So today we are basically going to talk about the diagnostic criteria. So what really is bipolar disorder, what it actually looks like, and then what empirically supported treatments we know are available. So first I'll just go into the diagnostic criteria of bipolar disorder. So if somebody were to come in and see me for an official, let's say research diagnosis, the first question I would ask them is, in the past month, has there been a period of time when you were feeling so good, high, excited, or on top of the world that other people thought you were not your normal self? Typically, people will say no to this, but some people might say, well, sure, and they're often referring to times when they were kind of hyper, or they were celebrating something, they were just feeling really up. And so then you'll want to follow up. So what has this been like? Was it more than just feeling good? Have you also been feeling like you were hyper or wired and had an unusual amount of energy? Have you been much more active than is typical for you? So maybe you're doing a lot more. You're like cleaning your entire house. Work is all of a sudden super productive. You're just out and about every day. Then, they might say no. They might say yes. You might also want to assess whether they were feeling irritable, angry, or short-tempered for most of the day, nearly every day for at least several days, because sometimes mania can look less like the super ecstasy feeling and a lot more like this kind of skin-crawling irritability and this kind of wired feeling.
Yeah, the common thread, so it could either be happy or this angry, but the common thread of mania is this expansive energy. I usually use those words to describe, okay, you've been irritable before, but was it with this expansive energy that came with a lot of more activity, like you said, and also lack of sleep. Sometimes even just beliefs about themselves can be exaggerated, like they suddenly believe they have magical powers or that they could do anything. So sometimes that means in a positive way, like they could write a book in a night, or they could do anything like no one could get in their way and they get into every fight on the street. So, yeah.
Yeah. And so, sometimes having this self-confidence can feel really good and it can be really reinforcing, but sometimes these can edge into grandiose beliefs. I'm much smarter, I'm much better than other people, I have superpowers. Another pretty clear indicator is if you only need like 3 hours of sleep and then you feel totally rested. So just sleep is just not even an issue for you anymore. That's how energized and wired you are. That's usually a question that people will test out of. That's like one of the first questions I'll ask, because they'll say, oh yeah, I was feeling pretty up and hyper and good, but oh yeah, no, I definitely still needed 8 hours of sleep. Or if I didn't get that, then I was really tired. Also looking for things like excessive talkativeness, people maybe stopping you, trying to figure out what you're saying because you're talking too quickly. Thoughts are really racing through your head. You're really easily distracted. You're, again, I already mentioned this, but you're spending your time in such a more enthusiastic, driven, kind of to the point of frenetic ways. You might be much more sociable, you might be going out a ton, and then, this can lead into some real impulsivity. So you might be drinking a lot, doing drugs you wouldn't normally do to an extent you wouldn't normally do them. You might be spending money on things you would never spend money on before. You might be having a lot of unprotected sex with people. So that impulsivity is something to really, really look out for, because people can get in a lot of trouble this way. And you might be spending money you don't have. You might be putting your body at risk. So bipolar can be, it can be a really dangerous condition. And we've been focusing solely on the mania right now, but there's also this depression component.
Yeah, and also to clarify, there's two different kinds of bipolar disorder. So just to get a diagnosis of bipolar 1, you need at least one episode of mania. So just as all the things that you described, Jacqueline, at least a week of those symptoms altogether. But people who have those symptoms but a shorter period of time or maybe less intense, that's called hypomania. So if you have hypomania, you might not get a diagnosis of bipolar 1. I call bipolar 2 the more sad one because there's a lot more depression. Is a little bit more hypomania, not a full-blown mania. So there's two different kinds, but you need a diagnosis of the hypo or mania in order to be in that bipolar category. Otherwise, it's depression, and it could look exactly the same. Someone very, very depressed, but they have one episode of mania, and then boom, that's bipolar disorder.
Yeah, I mean, and it's not like one of these is better than the other. I mean, bipolar 2 comes with, more depression, but that hypomania might not be reaching to the level of hospitalization or really risky life decisions. So both can be really debilitating, and both can be totally survivable. It's really the case.
And also, this is a huge caveat that actually I've seen a lot of this in my clinical experience. But so I don't know if some medications actually reveal an underlying bipolar disorder or it triggers a manic episode. But I have seen situations where someone is suffering from depression. They're treated with a medication and not carefully followed up by their provider. And actually sometimes medication switches will lead to manic symptoms. So they're depressed, they might be on an antidepressant, and then it kicks them into hypomania or mania itself. So if people do get antidepressant or any kind of new medications, make sure you actually are following up with your healthcare provider, doing the follow-up appointments as they recommend, because it's super important to really catch those moments. Not to scare everyone, it's still important to be medicated, but it's important to follow what your doctor says to prevent something like that.
Yeah, I do think of psychopharmacology as an area where you really want to have some patience in the beginning, which can be incredibly difficult to do if you're severely depressed or anxious. But it can take a while to find the right medication for you. I mean, it can be as simple as 2 different SSRIs, so acting on the same processes, but one could make you really anxious and to the point where it can have that kind of skin-crawling irritability and frustration, kind of hypomania. And then the next one will work. So, definitely something to closely monitor with your psychiatrist. Kibby, have you had experience with patients with mania or with people is this something you've witnessed firsthand?
So people who are actually manic don't come in for psychotherapy that often. So I haven't actually had a patient who's sat down in my office for this, but I've seen it personally. And I've seen it a lot when I worked in the psychiatric emergency room on internship. So my personal experience was really my first brush with bipolar disorder. And I always have that memory in my mind because it really reminds me of how debilitating that disorder can be and how extreme it could be. So I understand that people can often be scared of it, but because the behavior is just so out of character, that seems kind of alarming to the people around them, especially. So, of course, I won't say personal information to protect this person's identity, but I was on study abroad in college, and there was somebody who basically had a manic episode, and this is how I found out. I mean, I think what happened was she might have a change of medications during that time, or wasn't taking her medications as carefully as she should have, and was taking other kind of drugs. So I think there was this kind of biological component, and also just stressful being away from home. So stress can be another trigger of mood episodes. So I walk into our photography class in Italy, and I see photographs everywhere, all over the room. We were in a classroom full of other people, other students, and the teacher, and there's photographs everywhere. And there's this person who looks disheveled, just wearing different things that I've never seen her wear before, like feathers and stuff. And she had spread out all of her photos on the floor and was dancing around the room and singing, playing music on her laptop, and just singing and dancing. And I looked at the teacher, and he just looks terrified. He was like, what's happening? And she grabs me and starts really rapidly talking about how she's doing a photography book, and She's just so anxious because she looks at all these pictures on the floor and all she can think about is whether the window will open and all the pictures will blow out. Just things that didn't make any sense. But she looked happy. She looked like, I was just like, okay, like, whoa. But then it started to escalate after that. Like, she started to steal things from her roommates, just like pieces of clothing. She has stolen things from strangers. She was doing more drugs, and she would cook in her house and use every single pot and pan there was for one meal. And said one day that she wrote a 500-page book about her experiences in one night. And she's going to do a photography. She's going to do a photography exhibit of her experience. And all the pictures were just pictures of like street signs and the floor. So it just, we were all so alarmed because normally she's like a very even-keeled, lovely person, almost shy and quiet. And so pretty soon she got help that she needed and went home. But it was just, it was shocking. It was just like the most out of character I've seen somebody in my life. So that was, and she wasn't sleep. All the things that you said, she wasn't sleeping, wasn't eating that much, felt like she had energy, felt like she could write a book in one night, and I think did. So just had this extreme amount of like activity and grandiosity and impulsivity that just was totally out of character. So
is this something she wanted out of? Or, was there a sense that she enjoyed the mania?
I think that's a really good question because I think, and I could be wrong, I think different people with different levels of insight and experience with their own manic symptoms might feel differently, but from what I've heard, watching her in the moment and what I've heard from other patients is that when you're manic, it feels incredible. So you don't want it. In fact, a lot of people who are bipolar have suffered from depression and suffer from the opposite, right? Like no energy, doubts about themselves. And then they switch to the opposite and they're like, that feels so good. And that can actually be really hard for medication compliance. So it's treated with different kinds of mood stabilizers, like lithium and lamotrigine and things like that. But they might not want to because of the side effects of those medications, but also because sometimes the manic symptoms feel really good. So no, in that moment, she was on top of the world, but everyone around her was really worried.
Do you remember how she decided to accept treatment or to go home? Or how this normally happens with bipolar patients? I mean, is it just they ride out the manic episode?
People around her notified her parents and the program, and I think that they went and took her home. So I think, I don't know, levels of insight during mania can be really hard, but I think there might be a moment where people go, hey, you're doing things that are dangerous and we're worried about you. And usually they're brought to the ER for that or hospitalized.
Well, it really emphasizes the point that friends and family of people with bipolar disorder are enormously important. Yeah. Because, they're not, if they're experiencing that more agitated type of mania, then maybe there's more compliance or willingness to medicate. But this sense of euphoria and tremendous productivity, which isn't necessarily quality productivity, I guess it's case by case.
It depends. There are lots of famous artists and famous people who are known to be most productive when they have an episode. Like, I don't know if he's properly diagnosed, but like Kanye West have definitely had moments of, and a lot of famous painters. So, it's hard to say she was very smart and very lovely. I don't know if her 500-page book that she wrote in one night was like a great work of art, but for people who might have, I don't want to say more talent. You know what I mean? I don't know. It doesn't mean you become a better artist, but the people who have talent maybe.
She wasn't a novelist.
Right.
This is really illustrated in Homeland, which of course is a dramatized TV show, but the main character has bipolar, and she would purposely go off medications at times because that would increase her productivity, and she would find connections at times, and that is not advisable. But it just illustrates the point that medication compliance can be a really difficult road to travel for people with bipolar disorder. especially if they feel like the medications they're taking flatten them. And yeah, they're contrasting this experience to their depression.
Yeah. I mean, I will say that I know what I just described sounds extreme, and you're probably thinking like, oh gosh, that girl, is she okay? Or other judgments, but her story is another one that makes me realize like how much treatment can actually make a huge difference, because I mean, it was a mess. It was really a mess at the time. But as far as I know, she got treatment and is living a happy life. She's working and has a beautiful family. And so it is, you can have a life if you manage the medication well and the treatment well. So there is hope out there, and there's really no sense in judging these people or stigmatizing or just thinking that they're crazy. Like, there really can be, when someone gets properly treated, it could just be life-changing. So
yeah, I spoke with a good friend of mine who has bipolar disorder, and the one message he wanted to convey was that there's a lot of stigma against people with bipolar, and that's because a lot of people who are bipolar, who have BD, aren't on medication, and they do things that are damaging to their relationships during that time, or they scare people during that time, and that creates havoc, in their relationships. But the people that are medicated can do fabulously. Can I sing my song now?
Yeah.
Okay. He wrote a song. He wrote a song. It goes a little like this. Maybe he's born with it. Maybe it's lamotrigine. That's his love song that he wrote to Lamictal, his bipolar medication, which is the official name for Lamictal is lamotrigine. And he's somebody who actually was diagnosed as a kid. He was put on lithium and another point decode and really disliked both medications, and so went off when he was a late teenager and stayed off for over a decade. Convinced himself that he had cured himself. And then he was telling me that it wasn't until he moved to a quieter place, was no longer in New York City, and was alone with his thoughts in his mind for a long time that he realized, wait a minute, my moods are cycling like crazy. Like this isn't normal. Not necessarily like with extreme rapidity, but just not being able to really predict or control his emotional state. And he voluntarily went on Lamictal and now sings love songs to it. So
that's great.
In the form of a Maybelline ad. But
just so we don't get sued, we'll give credit where credit's due. That's actually a really good point too. In his story, it's a common thing where, because mania or manic symptoms are not sometimes are very rare. Like maybe someone had it once. And they think, oh, I hate taking this medication every day. It makes me feel XYZ, any kind of side effect. I'm fine. Maybe I'll just go off of it and I'm better now. And then they might, have another episode. So it is really unfortunate, but it's staying on the medication really seems to be the thing to do if you have bipolar disorder. So
yeah, it's incredibly important. The caveat is that not everybody responds to it. I think it's about 50% of patients respond well to medication, and of that, another 50% are not compliant. So, that does complicate matters. But it is true. I mean, when you are experiencing mania, there's not a whole lot that psychotherapy can do. I mean, it's almost like there's no route into that mind. I mean, it's so explosive, there's so much kind of chaos that it's really difficult to adhere to a psychotherapy approach, and that's when medication really, really comes in to save the day. Another thing that comes up a lot in terms of questions I get, we both study borderline personality disorder, and these two disorders are so frequently mixed up, and not just because they should have the same acronym, but because they look so similar. Kibby, how would you how would you tell them apart, or what would you tell people are the main differences?
Yeah, we get a lot of people, especially in DBT, especially in our treatments, people who got the diagnosis for bipolar disorder and actually have BPD and vice versa, right? And the reason why they look so similar to clinicians sometimes, especially if you haven't seen someone over a long period of time, is that sometimes a patient will describe doing impulsive things or having mood shifts where they're suddenly freaking out and screaming at people and then they're depressed and withdrawn, right? So this kind of like lability, we call it, like this really up and down presentation of emotions and behavior. And so, that could be hypomania, that could be borderline personality disorder with that emotion dysregulation. So it's really hard to tell for a lot of clinicians. And often that will determine the medications and treatment and might not be appropriate. So when I learned how to diagnose the two, I learned that a question to ask patients is, you ask them both, do you have like up and down moods, or, how quickly do your moods shift, or what makes them shift? People with bipolar disorder, yes, stressful things going on in people, like stress in general will maybe trigger a manic episode, but it will look different in the sense that it's not like people who have BPD tend to react to things going on in their day. Someone said something nice, they feel great. Then they broke up with someone, they feel terrible. And so it kind of links to something that's going on in their life, and they might just have the kind of almost like normal responses to things, like kind of an up and down, but, more extreme up and down, right? Mm-hmm. People who have mania, it's not really reactive. Like stress can bring it on, but it's not like the mania is because that they had a good day. It'll come on and it'll seem like a biological thing where it kind of stays for a long period of time, like a couple days straight or a week straight. And also like going with this expansive energy, like they don't need to sleep, as you mentioned before, they don't need to eat. So yeah, it's really, really nuanced differences, but I think that's what whether it's reactive to life events is the thing that my someone who trained me in diagnosis taught me.
Yeah, I mean, a bipolar disorder is a mood disorder and BPD is a personality disorder. And so, I mean, there's a big difference there already. When you're thinking about a personality disorder, it's almost more pervasive. I mean, somebody with bipolar disorder can be medicated and can be fine. I mean, there's not necessarily like these big swings go away. There aren't personality changes associated with it necessarily. People with BPD, I've heard it described as like having emotional nerve endings at like on the outside of your skin. Like everything hits you so hard. Mm-hmm. A slight could be seen as major rejection. So these like great fears of rejection, of abandonment, ways of dealing with things interpersonally. It's just much more about like the day-to-day living, and how they experience themselves interpersonally versus somebody who is just sort of honestly taken on a roller coaster by their brain chemistry.
I will say that I have also seen cases that have both.
Yeah.
So all we're saying here is if you are experiencing any of these or you have a loved one, get a proper thorough diagnosis with not just a doctor that sees someone for 10 minutes, but just like really an in-depth psychological assessment.
I know someone who I would say fits the BPD profile, walked into a psychiatrist's office and was given a diagnosis of bipolar immediately, which is an inappropriate way of diagnosing somebody. So if that ever happens to you, major red flag. It is interesting that they can coincide easily. I mean, like, oftentimes bipolar disorder is diagnosed in children and adolescents, which can I think set off some of the identity concerns and interpersonal concerns that can turn into BPD. Having extremes of emotions might not be validated by other people in a way that can help you form like a really solid relationship with your feelings. Can push people away, can cause a lot of rejection, which can cause rejection sensitivity. The deep lows of depression can lead to suicidality and self-harm and all these things. It doesn't totally surprise me that they can be comorbid, but
That's interesting.
But they are distinct. Okay, so I just want to introduce a really great paper that was written by Dr. Kibby McMahon. This might surprise you since she has no memory of writing it, but it does a really great job of detailing all of the, well, not necessarily all of the, but like the major forms of psychotherapy that are really useful for bipolar disorder. And it's specifically targeting the depression, the depressive episodes in bipolar. And that's, again, because, mania isn't something that is necessarily going to be responsive to treatment. However, a big component of these therapies is helping people get really, really in tune with the kind of precursors to a depressive episode or a manic episode, so that they can comply with medication, get themselves help, prevent mania from occurring, which is absolutely essential. So, Kibby, when you revisited this paper after having it vanish from your memory for 5 years, what did you learn?
Yeah, that's pretty embarrassing, mostly because I wrote it in the beginning of grad school, and as you know, grad school's a blur. And when I wrote this paper, I wrote it in my first year, and it was a really good project. And when we were doing a research, I remember all the different things that I learned from writing it. So basically, this paper I wrote is a review of different evidence-based treatments for bipolar depression. And the reason why we wrote that is because, as you said, psychotherapies, like behavioral interventions, are not, back when I wrote it, maybe it's different now, but not so effective when someone's actually in a full-blown manic episode. But the depression is still a problem, and if people have bipolar depression, they might not be able to take the regular SSRIs or other kind of medications because that could increase the risk of mania. So it's still, like, the depression is still a problem. So I wrote this review, and I'll put it on the website because it actually gives like pretty accessible and very simple explanations of the different treatments and how they work. And most of the treatments that I looked at, the main focus is to make sure that person, the patient, tracks and monitors their own flags that they might be shifting into a manic phase or a depressive phase, as you said. So monitoring their sleep, monitoring their emotions or other kind of behaviors like eating or impulsivity. So just helping them bring awareness to signs that they might actually be shifting into a manic episode. And for the depression, a lot of the cognitive behavioral therapies for bipolar disorders, the main part of that is to really address thinking and behaviors involved in depression that maintain depression. So beliefs about themselves and the world that might be negative. So you target those, really look at those and teach a person how to work with them. And engaging in positive routines and behaviors to help that person stay less depressed. So exercise or rewarding activities, right? The normal cognitive behavioral therapy for depression. But there's a couple of treatments I especially for this podcast, I thought it would be really interesting because it involves beloved ones.
Yeah.
So the first one that I read about, which is really cool, is a family-focused therapy. And that's really interesting because there's been research showing that families that have high expressed emotion, which is like very critical, aggressive, or overly involved emotional expressions, like kind of intense, unpredictable, and kind of scary emotional expressions, like maybe a lot of fights or a lot of, kind of unpredictable emotional chaos in the home. Those kind of family expressions put people at risk for schizophrenia, but also for bipolar disorder. So there's a therapy called family-focused therapy that's actually designed to work on how a family expresses emotion. So it'll engage the whole family. It'll talk about these risks, and it'll teach like communication skills and other kind of emotion regulation skills to the family. So I thought that was really cool.
Yeah, I would imagine the problem with that would be compliance, getting everybody in the family to go to treatment. Yeah. But imagine how powerful it would be if everybody was able to recognize, like, this is a family systems issue. Like, we have to learn how to help each other along and how to support each other and learn through this. And it also includes this part about, like, bipolar disorder can be as extreme as you were describing earlier, and the other family members really need psychoeducation about that to understand what is going on, and that this isn't a personality flaw. Like, this isn't like this person has just decided to betray your trust and sleep with other people, spend money, like, and anything that might occur in the context of a manic episode, that this is really the disorder talking. So having every member of the family unit be really, really educated in understanding this disorder is crucial.
Yeah, loved ones and bipolar disorder, loved ones are really key here. They're the ones who notice when there's shifts in people's behaviors and routines and character, and they're the ones who can flag problematic behavior and get help. So, so I love how family therapy can just really, makes that the central focus. And the other one I wanted to bring up, which is really cool, there's social rhythm therapy that's combined with interpersonal therapy. So social rhythm therapy is really cool. I just love this, especially now in the pandemic. So there's research showing that disruptions in circadian rhythms, sleep-wake cycles, or social rhythms. So like, when do you wake up? When do you talk to your first person? Do you leave your house and go interact with someone? Do you take a walk with someone? Do you eat meals with people? So basically, we usually have social rhythms in our day that kind of are linked to other people. And when those get disrupted, sometimes that could be a risk factor for mood shifts. And I thought this was really interesting to kind of revisit after the pandemic, because we've seen so much increase in mental health issues in the past couple of years. And a lot of it, I think, has been because we're so used to being regulated. Our days we're so regulated by people. You have your cup of coffee with your partner, you go to work and see your coworkers, you talk to your friend we live with people, and with remote working, we've just are spread all over the place, and we could feel really disconnected from like the rhythms of life and the day. So to think that is like a risk factor for bipolar disorder, I thought it was fascinating. So social rhythm therapy itself, usually the goal is to create more consistency with these routines. So really setting wake times, social interaction times, evening meals or meals with other people, and bedtime, so really regulating those routines. And it can be combined with interpersonal therapy, a really well-known therapy for depression, which it really focuses on how the really interpersonal aspect of depression. We've actually talked about this before in a previous episode on depression, but it basically will target different parts of identity and our roles in relationships that might lead to depression, like unresolved grief, big transitions, disputes and conflicts over your role, and things like that. So the combination can be really effective. A social rhythm therapy and IPT can be really helpful.
I also liked how IPT for bipolar included this part about the patient really accepting this about themselves, that they are somebody with bipolar disorder, and the kind of identity dispute that can arise from that. And just pointing out, this is a lifelong condition, and it's something that has to be managed, and that can be really hard to acknowledge and have to live with. I mean, my friend tried to say that he cured himself, and it wasn't until his mid-30s that he's like, whoop, never mind. So that's a really important part. I love how on page 12, for those of you who look at this paper, you have this sort of summary of how to know if a therapist provides evidence-based psychotherapy for bipolar depression. And so there are some guidelines here. Does the therapy offered include psychoeducation about bipolar disorder? I would say that any therapy offered for a specific disorder should probably include some level of psychoeducation. And again, I think this is especially important for friends and loved ones to be provided as well. Does the psychotherapy address medication compliance? We have hammered home the point that medication compliance is pretty essential for BD, so this should absolutely be a part of the treatment. Is there a clear component of monitoring problems, mood, and or medication? I mean, this is a disorder in some ways about predicting and monitoring. When are these mood shifts going to occur? Can I get ahead of them? And so monitoring this is, again, really important. Is establishing routines encouraged and directly assessed in therapy? Think about how much your sleep and the food you're eating and the alcohol you're drinking, I mean, all these things can radically affect our mood. And so really being regulated with this is a great way to keep the mood regulated as well. Can the therapist describe his or her training in the modality of the therapy offered, and is the therapy offered an evidence-based treatment of bipolar depression? This is pretty much advice that I would give for any therapy. If you are looking for therapy for anxiety, go ahead and ask this therapist, like, what evidence-based treatments are you trained in? Have you had experience offering this therapy before? And so same goes for bipolar. Yeah,
and if you're not sure about asking about their training, you could actually ask, like, what's your approach? Like, how do you treat this bipolar depression and bipolar disorder, or any kind of disorder you're talking about? They should be able to list a model, right? They should be able to say, so we believe that bipolar depression is what maintains depression is the thoughts and behaviors involved in depression, and so we target those with these skills, right? It's someone who would be able to describe their approach to how they treat something is a really good sign that that person's well trained. So,
yeah. Okay. Well, I think that is all from us today. Again, we are going to bring in an expert to talk more about this, but we figured we would give an overview of this disorder and treatment approaches since this has been so requested. So thank you all for listening in. And Kibby, want to close us out?
There's a lot of good resources for bipolar disorder out there, and we'll definitely link that on the website. I'll just say that my paper is called Psychotherapeutic Treatment of Bipolar Depression, and I'll link that to the site too. So look out on the site for the different resources you can dig into.
Awesome. Okay. See y'all next week. By accessing this podcast, I acknowledge that the hosts of this podcast make no warranty, guarantee, or representation as to the accuracy or sufficiency of the information featured in this podcast. The information, opinions, and recommendations presented in this podcast are for general information only, and any reliance on the information provided in this podcast is done at your own risk. This podcast and any and all content or services available on or through this podcast are provided for general, non-commercial informational purposes only and do not constitute the practice of medical or any other professional judgment, advice, diagnosis, or treatment, and should not be considered or used as a substitute for the independent professional judgment, advice, diagnosis, or treatment of a duly licensed and qualified healthcare provider. In case of a medical emergency, you should immediately call 911. The hosts do not endorse, approve, recommend, or certify any information, product, process, service, or organization presented or mentioned in this podcast, and information from this podcast should not be referenced in any way to imply such approval